Kia ora, my name's Margie Olds, and this is the Glenohumeral Gurus podcast. This is a podcast for clinicians interested in shoulder rehabilitation. I'm a shoulder therapist based in Auckland, New Zealand, and in this podcast, I interview clinicians and researchers across the globe about their research and their clinical practice on how we can improve outcomes for people with shoulder pathologies. The aim is to learn, laugh, and try to work out how we can help people with shoulder problems. Enjoy the podcast. This episode is brought to you by Flawless Motion, shoulder braces that are designed for people with shoulder instability in male, female, and bilateral versions. So check out flawlessmotion.com for your shoulder brace requirements. We've also just expanded now to the UK, so if you live in the UK or Europe, you can get your shoulder braces much more quickly. So check us out at flawlessmotion.co.uk and you can check out our shoulder braces there. Cheers. Hey,
I'm ready.
welcome back to Glenohumeral Gurus. In this part two of our rehabilitation focus now for motor learning, it's my pleasure to welcome back Wieger Heijink for this session. In part one, we talked really around knowledge of results and how important that is, around implicit and explicit learning when patients are learning how to move again. And we also talked then about that external focus in the rehab. Is there anything, Rika, you wanted to add that people, before we kick off the session that is now around the rehabilitation, things that clinicians should know if they missed part one, what should they know about in terms of the rehabilitation aspect?
Well, thank you again for having me. I'm really
You're
delighted.
welcome. Yeah, likewise.
Um, I think the important thing to know is that moving everything isn't a linear system. It's non-linear. You can't
Mhm.
give one exercise and expect that to happen. So you can't say we're training the X rotator, how do you, I'm losing it already.
Yeah.
You can't train your calf and expect that the function will be better. You can't do a scapular setting movement, expect someone to play volleyball again. That's a very linear way of thinking, and
Mm,
moving is non-linear. So that's why we
yeah.
do it implicitly and use other stuff in rehabilitation. I think
Do you
that's
think
the
that comes
important
from a
short
lot
message.
of training around deductive reasoning? Like I spend a lot of time listening to people, they tell me their problem, they tell me to make a diagnosis. Do you think that's how we have landed up in this really linear way of thinking? Why do you think that
Yeah, I
is?
think that's one part, and the other part is when something is stuck, like the supraspinatus, then the idea is, well, if that's the tendon that's not doing well, we should put load on it and everything comes well.
Mm,
It's
mm,
also one thing. And also the models of learning, they were like that, like Fritz and Posner, they were like first you have to do the conscious movement, then the unconscious, then you have to
yeah,
automatization and it the Smith-Scheme theory, it's also very linear. But now
yeah,
you have the ecological approach and it's
yeah.
all questioning all the assumptions.
Mm,
And yeah, I really like it because they ask a lot of questions and the other theories can't give the answers. You
yeah.
get stuck in it.
Tell us, so I
Yeah.
wanted this session to be around rehabilitation principles and what you actually do with your patient, but I'm really curious around this ecological validity. I've spoken with George Davies in a separate podcast
Yeah.
around that. Tell us about ecological validity and why you think that's so important.
Well, the ecological approach says everybody has to deal with his environment. You can't take somebody out of his environment.
Mm,
And moving is about having a task. It's like you're getting hungry, you want to grab something, you have to go start moving. You go to the fridge, you go take somebody, take
yeah.
something. Um, so moving is about intention. You have to have an intention in your movement.
Mm,
So that's the one thing I use in my rehab. I always put an intention in it.
yeah,
People need to
okay.
have an intention of movement to change their motor patterns. And we also change the environment all the time. So we have to deal with different circumstances. It's like Rafael Nadal said.
Mm,
Um, Rafael Nadal quoted once, I've played so many balls, I uncountable millions of balls, and never one ball was the same. So
yeah.
I've never hit the same ball in my life. So I have to do a slightly different thing every time to get a good result. When I
Yeah.
would do this exact same thing, I would have gotten millions of different results. But I want the result, the ball, I want them to be exactly in
Mm,
that spot. So I
mm,
have to change my modem pattern all the time.
yeah.
And that's what we do with rehab. We have to change these modem patterns all the time, get them really resilient, so we're not
Mm.
automating autom
Yeah,
that's
it's
a
a tough word in
difficult
English,
word.
let alone when it's not your
Really great for a
automation. Like,
podcast where you can't come out of your words. So we don't want them to repeat everything. We want them to be
yes.
skillful under different circumstances.
Yes, yes.
That's a big
And I would
difference.
have layered that up, like I would have, but again, you would say that my approach is quite linear, that I need to be approaching it from lots of different angles. That's what you would say, because I
That
would
would
have
be my
started.
advice. Yeah.
Yeah,
Yeah.
yeah, that's what I'm learning from you today.
Yeah.
Tell us what that means for clinicians listening. If they were, so somebody comes into their clinic, they have, let's give a little example of they have been too much overload. It's a supraspinatus tendinopathy. They were cutting their hedge in the weekend. They now present to you from a deductive process with the supraspinatus tendinopathy with some kind of bursitis. My approach
Yeah.
would be isometric loading in a pain-free range. What is your approach for this person?
When they come acutely to me, when it's
Yes.
happened last week, I would say, good luck, have fun. I think you will heal in a few weeks. If you don't, come back to me.
Okay. Maybe with a little advice around inflammation and pain loading and
Yeah,
maybe some other
like that.
education,
Like
like,
that.
or
So I would say it's very acute. It's very normal that your body is moving differently.
yes,
I can give you some exercise to keep your scapula moving, everything, but you probably will heal. But
yes,
we can make a checkup after 3, 4 weeks. But
yes,
now we take a different example. This person has had it, but it
yes,
was been 1 year before. 1 year
yes,
before he
okay.
got into pain, got to 2 or 3 physiotherapists, and now he's coming to me. He's still in pain, and we can see that he's not moving very well, that he's restricted in his movements, that it isn't a frozen shoulder, that's a whole different thing. So I tested
Yes,
the capital, the external internal rotations are all free, but he has problems moving, his problems putting on his jacket and everything. So his movement patterns have been different now. I've altered. Yeah,
yes.
that's a nice case.
Yes, is a nice
Yeah,
case. And so
that's a
then
nice case.
that's a nice case. So acutely you
So
would say, hey mate, don't worry, it's gonna
don't
settle.
worry,
This
it's gonna
is
sit. We'll do nothing. But now he's been chronic, and
yes,
I think the main reason is because before he had adaptive movement patterns,
yeah,
because it's very logical, but now it's maladaptive. The time frame is much too long. I can make an
yes,
ultrasound, see if the shoulder is good. So let's assume everything looks good, but he's
yes.
in pain and he's in troubles. So what we usually find is that there's the mobility of the scapula is restricted
Hmm.
and that he's not capable of really using fast movements and everything because he gets in trouble there. Yeah.
Yes.
So
When you say
what?
mobility, sorry, I'm a granular kind of a girl.
Yeah.
You mean you would passively check to see that their scapula is not moving, or you mean you just watch and
Not
observe that their patterning of their scapula is different? What do
when
you mean by
when
that?
when the good side is going to 180 degrees, when you
Yes,
make flexion abduction, and
yes,
the other side is on 160 degrees,
yes,
somewhere misses 20 degrees.
yes,
You agree?
exactly. We could agree
Yeah.
that, but how do we know
Yeah.
it's
And
scapular movement versus
ve-
capsule?
ve-
How would we?
very easy. When his external rotation, internal rotations are free, we
Yes.
know that his glenohumeral joint is free.
But you do that below, I would do this then at 90 degrees to see
No,
if,
would do it at 0 degrees. So when the capsule in 0 degrees, external, internal rotation is totally free. the capsula is not restricted.
Yes, but it winds up more at 90 degrees of abduction. Here is not like all of the
Yeah, but
angle. You're not
that
bothered.
would be fun. That I mean, when the capsule is restricted, it's restricted in all directions. So
Yes,
when
but I
it's
can.
free at 0 degrees, we can assume that the 20 degrees there will not be from a scapula. It will be from a scapula or a spine or his AC joints. We don't have much other options. So that's for me
Mhm.
really simple
Okay.
clinical reasoning. And it really it comes out every time. Try
Yeah,
it.
I would probably disagree that in terms of loss of internal rotation here at 0 degrees is different than loss of internal rotation higher up. That's all. I don't want to argue the point.
Yeah,
I
well,
don't want to get distracted.
the problem is when I go to 90 degrees abduction and test it, it's probably painful because he
Mm,
is in pain. He has troubles there, but not from a scapula because everything is just, yeah, moving not well and everything. So I never tested there because it probably will hurt him. So I just don't do the test.
okay.
It's very easy. Yeah.
Okay. Okay. Anyway, back to
So
it. Back
let's
to our guy.
assume
We've make an assumption that it is then his scapula because he has full external rotation.
internal rotation. We can try it at
You
90
go
degrees. It's
behind back. You look for
behind the
behind back.
back. Yeah, yeah,
Yes.
yeah. When
Okay.
that's free, we have no other choice than it's the scapula or the
Okay.
spine.
We can
Yeah,
agree. Yeah.
we
Okay.
can agree. So what I want to do, I want to have movement of the scapula as far as possible without stress on the glenohumeral joint.
Mm-hmm.
And that's very easy when we go down, when I let him standing and he touches the ground, he can either bend his knees very much and touch the ground, and when he doesn't, he have to move his scapula.
Yeah. Okay.
Otherwise, he will not touch the ground.
Yeah.
And when he's touching the ground on that way, his glenohumeral joint is never in trouble because it's still in a
Yeah.
loosened position. And when I let him bend over, touch with one hand the ground and do it more cross, when it's his
Yes.
right arm, let him move to the left, he will need more scapular movement.
Yes.
So then I have a direction which is totally safe for the shoulder.
Yes.
I can have full scapular movement there.
Yeah.
And now I also want
It's
him to
not.
have
You then
control.
also bring him back because he is.
Yeah. In first, I really go forward because Norman de Hond, I think you know him. He's this Dutch teacher, Norman de Hond,
Okay.
really well known in Holland and everything. He did
Yes.
this really nice research that if you want to have full anteflexion, you need a lot of protraction in your shoulder blade.
Yes.
So when you're making retraction, you're not getting there. You can try it when you sit and you put your arms in retraction and you move your arms up.
Yes. You can't move.
You're restricted. Yeah, so we
Yes.
need a lot of protraction to get your arms up. So I'm always trying first the protraction exercises with
Okay.
a lot of
Okay.
success. Yeah.
Yes. Okay. Yes. And
So now we have a direction we can think we can get more mobility.
yes.
I want to train the whole system. So I also want the arm to have a lot of contractions, a lot of control there. And then I use the balance part. I put them either on a bosu or on one leg or standing on their toes. And
Yes.
then using this direction, so we have full mobility. But in this position very far away, you have to do use a lot of control. Otherwise, he will fall. He
Mm.
will not keep his
Yes.
balance.
Yes.
So then we're training already the muscle synergies
Yes.
in all these positions, and probably he will get very fast, be able to move up his arms.
Because then he can lift his arm overhead.
Yeah, and normally we can get that in one session.
Okay.
Yeah, not always, but most of the time in one session we already can make a difference. And that's a very strong thing because then people
Sure.
know that we have exercises that really do something for them.
Yes.
And we can teach them how to do it at home, and we can tell them a little bit about the pain, that it's pain is taking a little bit longer. We do some pain education there, but
Mm-hmm.
they get control of their own recovery.
Yeah, okay. And that just
Yeah,
improves their self-efficacy. We know
self-efficacy. Yeah,
how important the role of education is and patients understanding what the problem is, and also then they are back in control of things,
Back
aren't
in
they?
control. And when they notice the first time that we can do things they respond well to, they're
Yes,
very eager to train.
yes,
So we
they
never
come
have
back.
troubles with people not exercising because they know they have something they can
Yeah.
use. Yeah.
You get an early win on the board, isn't it?
Yeah,
Regardless.
yeah, yeah.
Yeah, that's what you're locking. And I would agree that's incredibly important in terms of
Incredibly important.
getting people
The,
on
the,
board and
yeah.
establishing that alliance.
In Holland, there's this tendency, and it's because of the payment thing, that the first time you do an intake, you do
Hmm.
the exam,
Yes,
and you don't treat anything. You get them back the second time, and then you start the treatment. I think this is the
yes,
stupidest thing you can do. You have to
yeah.
make a difference the first time.
Yeah, you have to
Then
get
you make them
people,
going.
yeah. I
Yeah,
would just calling it get a win on the board is what I would, that's how
yeah.
I think of it. There has to be something to actually engage people for them
To
to
engage people. Like
change that
exactly.
belief.
Yeah.
Yeah.
When you can get that the first time, yeah, that's brilliant. Then the patience is in your corner.
Yeah,
Yeah.
exactly. And then, so progressing through for our case with the 1 year
Yeah.
history of cuff problems, you've got
So
him
let's
moving here. Now he's able to
He's
lift
got
his
him moving,
arm.
he's able to move better, but he
Yes,
still has a lack of control. So then we make the exercises always harder and harder. And the harder
yes,
part is especially in the balance thing. So we
yes.
make
Okay,
the balancing act more difficult and difficult and difficult. So he will have to
okay.
use more control. He has to let go his stiffness. He has
Yes,
to learn to move faster, to get um, how do you say it? To get better control in every angle.
yes,
And
yes,
like you were talking with George Davis in the
yes,
podcast
yes,
about force rate development.
yes,
It's not about the force, it's about how fast can you get there. And
yes.
that's what we train in a very early stage.
Yeah,
Because
right.
with the balance things, you have to start moving very quickly, every
Quickly.
direction. So
Yeah,
you're training these force rates developments in an
yes.
early stage of rehab.
Yeah,
So at the
okay.
end, it's getting easier and easier.
Yeah, okay. And so then you just increase the complexity of the task
Yeah,
using balance.
every time. Yeah,
Yeah.
using balance, and for example, when we have the reaching task, we can all say, hey, I'm rolling a ball to you. You have to stop it with your hand. And I can
Yes.
choose directions and everything. And he has to be very far away, also out of balance. So he has to
Yes.
time it very fast. So we use the
Yes.
timing, we use every part of the coordination things, but we
Hmm.
always keep it with the feedback. There's always
Yes.
feedback if you're doing it
Yes.
well or not. And
Yes.
we have action perception coupling. We haven't mentioned that one.
No, let's talk
That's
about that.
very important. So we never say, oh, first we have to train your sensory system and then your motor system. It's
Mhm.
one system. You can't
Yeah.
separate.
Yeah.
He has to know what he's doing. Yeah. For example, when I'm uh, riding on my bike and want to
Hmm.
see if there's something coming, I want to perceive, I have to go moving. So I have to
Yeah.
move to perceive.
Yeah. Okay.
When I perceive, I can have feedback and move again. So
Mm.
these always connected. So
And
when
how?
an exercise doesn't have
Yes.
an action perception coupling, my statement is that is not a very good exercise.
So give us an example of that, a rehab example of how
A
that
react
actually.
example, for
Yeah.
example, standing against the wall for your serratus anterior, pushing it
Yes.
out.
Yes.
There's no feedback in it. You don't know how you do it well. And
Yes.
there's no action perception coupling. There's no way you can tell if you're doing it right.
Mm.
Yeah, so I don't think that's a very good exercise.
Okay. And so
For
instead,
example, another exercise when have you ever been on your knees on a Swiss ball?
yes,
Yeah? When you start trying to go from your knees to lying on your stomach on the ball without touching the floor, you can use your arms. Then you have a lot of activity there, but you
yes,
know if you're doing well or not, because when you're not doing well, you fall off. Yeah?
yes,
You have to get your timing right, and it's possible. You
yes,
can learn it very fast. You
yes,
can do it with your hands on the ground, with your hands on the ball. It's a little bit more
yes,
difficult. But then you have the action perception coupling. You know if you do it right.
Yeah.
Well, sure, you still have the control of your scapula and you have to stretch it out to come off, to come on it.
Yes.
So we're manipulating your motor system.
Mm-hmm.
And then the patient knows, hey, I'm doing well. Now I can do it. We can do it a little faster. We can change all these things and we can accelerate your skill acquisition.
Yeah.
And it's so much
But
fun.
tell me, it sounds fun. In terms of clinicians understanding principles, because there are some structured principles that
Yeah.
underpin your rehab here, isn't it? What should clinicians understand about that?
They should understand that motor learning is, I said it in the first part already, it's a
Mm,
bottom-up system. It
yeah.
organizes itself. That's really important. We shouldn't
Yes.
interfere with it. We shouldn't tell people how to move.
Yes,
We
but
should.
you apply some constraints around that. We talked about that. Tell us about when you would apply constraints and what that looks like so
Yeah,
that you
so
could shape
constraints.
people's learning.
Yeah, so what's important to know that constraints means we're giving them limitations
Mm-hmm.
in their options.
Yes.
So when I'm telling, I can give them another task or I can give them some rules or something, but they have to have limitations for their options. So there
Mm-hmm.
will be a big chance that they choose another way of moving.
Yes.
Yeah. For example, when somebody is really afraid of moving and is moving
Yeah.
very slowly every time, I can say, hey, well, let's make a match of it. Yeah.
Yes.
We have to
Yes.
go touching rings and somebody's calling and who's first wins.
Yeah.
So when
Okay.
he's a little bit eager and he wants to win, he has to change his motor system. He
His
has to
strategy.
use, yeah.
Yeah. That sort of leads us into, I wanted to talk to you about fear and the way that that makes people change. Because as you may know, I have this interest, I think, around fear and how that affects people's movement and what that might mean. And I've read that it makes people novice learners again, that it changes, it stiffens their system.
Can we have a little break?
Yes, of course. This up.
Yeah.
Hey Vika, it's so great to talk to you. I thank you so much. I understand you now have a family emergency you need to attend, but
I have to go to a family emergency. I have to call my son. He has been falling on a scooter, so I'm very sorry. We'll
let's
come back.
reconnect when your family is healthy and well.
Yeah, so I'm gonna save him now. I'm really,
Yes.
really sorry.
No, 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 it's
Yeah.
absolutely no problem. You go. We're gonna pick this up because I still have some more things to ask you. So now this
Yeah,
is a
so part
three-part
two we're gonna
podcast.
do next time.
No, part two is gonna roll and part three is then we'll do another part three.
Thank you very much, Maggie.
See you, bye.
Bye.
Talk soon. Bye. I hope your son is okay. And thanks again to Flawless Motion for supporting this episode. So, if you want to know more about the shoulder braces or other clinician resources, then head to flawlessmotion.com or flawlessmotion.co.uk for more information. Thanks for listening. I hope you enjoyed the podcast and found some clinically useful tips for your patients in clinic. Please subscribe to the podcast and follow me on social media to keep across the latest releases of the podcast. Don't forget, if you need a shoulder brace for your patients, then check out our shoulder braces at flawlessmotion.com. And if you want to know more about assessment and treatment of rehabilitation of your patients, then check out the online shoulder courses at margieolds.com. Otherwise, take care, enjoy, and see you next time. Please remember that this podcast is for educational purposes for clinicians only and does not constitute medical advice. Please consult with a qualified health professional or contact me to book an appointment for individual assessment and treatment. Cheers.